All right, are we already on volume-wise? Good, all right. Well, good morning, everyone. Welcome to everybody who's joining us online. Dr. Chen, we do have a small group. We were talking about in-person versus virtual. We have a much larger group of people who are actually watching still online. So we call it a hybrid Grand Rounds, but it's nice to have everybody at least fill in the room here. So we're really excited this morning to have our last Grand Rounds of the calendar year before the holiday break. And more importantly, our last visiting professor. We're very excited this morning to have Dr. Antonia Chen with us. Before I forget, CME color will be crimson in honor of her academic appointment and dress today. Perfect color. So our CME color will be crimson. And it's really a pleasure for us to have Dr. Chen. She is certainly a young star in the arthroplasty world. I've gotten to know her through the AOA. She was a former NATF traveling fellow, and she is started out her career at Thomas Jefferson and part of the Rothman Clinic, then moved up to Brigham and Women's. She's been a great mentor for many med students, like our own Eric Seacrest, who was one of her mentees at Jefferson, and has recently served as the program chair for the AHCAS annual meeting, which was, I think, all of your first real in-person meeting again, right after a brief delay. So it's really a pleasure to have her here visiting with us. I know the residents had a wonderful time with you at dinner last night. We'll invite you to come up and share some of your work on patient optimization, and following this, the residents and some of our arthroplasty faculty go through some journal articles and some cases. So without further ado, welcome to Charlotte. We're pleased to have you here and looking forward to the talk this morning.
Thanks so much. Well, I'm just really glad to be here. It's just nice to be in person again. I was saying we're doing our virtual Grand Round, so it's good to be here. And I'd say, despite my hardest efforts, I couldn't convince Eric to not go in orthopedics. So it goes to show the resilience of your residents.
By the way, when George said that on SAP this morning, anyway, he's wrong.
We both talk. So I'm going to talk about preoperative patient optimization prior to orthopedic surgery. And obviously my focus will be on joints, but this can be used across the board throughout all different specialties as well, not just in arthroplasty, but of course, arthroplasty is the best subspecialty in my mind. As an aside too, I wore the red, I have the crimson, but I'm actually a Yaley. So a little part of me dies every time I walk on campus, but that's okay. It's called nerdy humor. Anyway, so patient pre-optimization prior to orthopedic surgery. So I can click this. There we go. So I'll say thank you, first of all, to some wonderful people who are here. So again, it's really nice to be in person. You recognize yourself here too. So talking about Jefferson continuation, Brianna is actually in this picture as well with Eric. So they were both Jefferson med students, again, who I could not convince away from it. Joe, Peter Waters came out from here, and of course, Josh, thanks so much for having me here. It's a real pleasure to be here in person. We've connected multiple times throughout the years, so it makes a big difference to be in person and talking to each other again. I'd also like to thank other people as well too, Ortho Carolina. So that's Brian Springer behind a poster board in a hall while doing a conference call at a conference. I just thought I'd share that with everyone in case people want some background context here. So these are a bunch of individuals also who've made an impact on me too. Susan, obviously, Walt Beaver, Griffin Faring, as well as Drew Henderson was actually a fellow at Rothman with me. And if you want to know a little bit background about Dr. Brian Springer, that's his online picture that you can find from years ago. So dirt is amazingly easy to find on the internet, just saying. These are my disclosures here, none of which are 100% relevant to my discussion today. So what are we preventing? So let's see if this works. Oh, it does. There we go. Good morning. I hope you're not eating too much of a breakfast. So this is what we're trying to prevent, periprosthetic joint infection. That's a supine lateral hip, and that's what I use myself. Yeah, who's on call? Go. Easy C plus, you run. Either direction, towards it or from it. Depends what part of stage of your career you are. So it's a major reason of failure after total joint replacement and periprosthetic joint infections. As we do more cases, the number of infections are going to go up, not surprisingly so. So what I really want to focus on is preoperative patient optimization, prior orthopedic surgery for modifiable risk factors. There's a billion non-modifiable risk factors that we can't do a lot for. But when it comes to modifiable risk factors, these are the areas that I'm going to focus on because we are working on guidelines and things like that that can actually make a difference. So my interest in preoperative patient optimization started when I was in your shoes as a resident. So when I was in your shoes as a resident, I was like, I need to do some sort of research project. So MRSA and MSA swabs is what we got into. So one of our ID docs, Nalini Rao, who got me into the Musculoskeletal Infection Society later on, said, you know what, we're starting to do this MRSA swab thing in spine. I kind of want this to take off and let's do it in joints as well too. And I go, what's MSSA, what's MRSA? So I had no idea what it was at the time as a resident. So what we started doing is we started doing screening and decolonization. So I'm going to curiously ask you here, do you guys do screening and decolonization here or just straight up decolonization? Okay, it's just decolonization. So that's something that's probably changed over time. Initially, when we started this, we did preoperative patient decolonization or we checked them and then tested them afterwards and then treated them. So what we would do is in the preoperative visit, 2 to 6 weeks prior to surgery, obviously changed in the context of COVID, we do an intranasal swab. The nice thing with COVID is it made it a little less weird to stick something up your nose and take a sample. So kind of a win that way. So we would moisten the swab, stick it up the nasal nares, and you go down the nares and you go up in the septum area. And we used to say that if it felt a little uncomfortable, you were doing the right thing. Test it, it was MRSA positive, then we get Ancef and Vanco as part of their preoptimization, and they would get treated with mupirocin and chlorhexidine. It'd be 5 days prior to surgery. Now we do chlorhexidine prior to surgery for everyone, but the mupirocin only if they're MRSA or MSSA positive. The real question is, does it work? So this is an older study at New England Journal of Medicine. And the idea is they looked at, okay, just because you did all these things, does it actually make a difference at the surgical site? And the surgical site infection reduction risk was 56% of infections, not just the decolonization, but infections. That's pretty significant to be able to reduce the number of infections just by one simple intervention. It's a randomized study that they did so. So this is our first purview into it, again, when I was a resident. We looked at staff screening and decolonization and orthopedic surgery in general. And we found that the percent reduction you can see throughout the areas, 50% was kind of the average there, but up to a 200% reduction in surgical site infections based on a systematic review. And again, this is Dr. Rao, where I really got the idea to work on this. So then we took it to the next level and we said, okay, is it effective at reducing colonization? We didn't look at infection yet, but we looked at reduction in colonization. So in our MRSA patients, it's about 2 to 5% of patients who have MRSA. And in this case, we saw about the 5%. And on the day of surgery, they had 0. So that's a pretty good sign that we were able to clear it. The interesting part, though, is on MRSA, MSSA, we got 20 to 25% is what the national average is. So we were in between that range when it came to the percentage of patients who were infected by MSSA. But the reduction went down, which is significant, but we still had 10% patients, or sorry, we had it was actually 3% of patients who were positive for MSSA. And we went back and looked at these patients. Some were not compliant, right? We gave them the stuff we said we could do, they just weren't compliant with it. But some got new infections from it or new colonization that we didn't detect initially. So just because we didn't detect initially doesn't mean they can't become positive on the day of surgery, which is why some people started instituting universal decolonization protocols. So the pros of doing this is that it directly reduces Staph aureus colonization and reduces the likelihood of surgical site infections and periprosthetic joint infections. Sounds like a win. Why don't we just do this all around? But there are some cons. One, there's an additional cost to screening decolonization. Again, why some people have switched to pure decolonization. 2, it can miss positive results. Who's responsible if you miss positive results, right? If someone comes in positive and someone doesn't call them and they get a staph infection, you could be sued for that technically. And finally is antibiotic resistance. You're giving mupirocin, and because of that, you're giving it to everyone. They're finding some rates of increased mupirocin resistance. So what can we do for that? In theory, we can actually use other products. So this is a sticky povidone iodine. This is a commercial version of a product. And so we said, okay, this is nice that this product exists. Does that make a difference? Can we compare that to other things? So this is when I was at Rothman, we looked at this and we did a randomized control trial and we said, all right, we're going to take 3 products. We're going to take that sticky product. We're going to take saline and see there's a control, and then those betadine swabs just off the shelf, right? So you just take them in those big betadine swabs. We tried them on each other. It's not fun, but it's not bad. It's a little bit big and it gets a little bit brown. And this is what we found. So at 100% colonization rate in the beginning, we took only patients who were positively colonized, and then we treated them. And at 4 hours, when the maximum shedding happens, because you're thinking in the operating room, they're shedding from their nares and it can get to the surgical site. So they got it right before in the pre-op holding area. We gave them the saline, we gave them the povidone iodine, and then we gave them the special product. And you can see that it drops down, all of them. So just the fact that you're sticking something mechanical and moving it around the nares helps clean the nares, which is good. We found that the one that was a product actually had the most reduction in colonization, but all of them reduced colonization. And at 24 hours, they rebounded. And that was it. It's a temporary measurement. It's not a treatment like mupirocin. So we actually saw this happen. We said, okay, for cost purposes, we now take those big beta-9 swabs, our nurses stick them in our patient's nose, and we stick them in everyone. So that's our universal decolonization now. So we don't give everyone mupirocin, we give everyone chlorhexidine, but we skip on the mupirocin part because our ID doc said we got to be careful of antibiotic resistance. Makes sense. So that's what we do in practice now. One of the next areas is obesity. So in the South, everything tastes good, let me tell you. There's no doubt about that. I lived in Durham, North Carolina for a year. I ate a lot of fried chicken. I'll just leave it at that. And it was delicious. I didn't know what Bojangles was until I came down here. Wonderful product. Not good for me in the long run. We'll leave it at that. So the obesity epidemic, as you know, is blowing up, not just in the US, but in the world as well too. This is actually a CT scan I got when I was in residency. I call it the positive heart sign because there's a lot of adipose tissue, but it looks like a heart, so it's kind of nice. But this is not this is a smaller boned individual, unfortunately. But what's the problem with obesity, right? We know that there's a lot of soft tissue there, and that's problematic. But more importantly, actually, these patients are immunocompromised. So these obese patients, they looked at it, have increased levels of cytokines. So increased levels of interleukin-1, and beta, interleukin-6, and TNF-alpha. And we know this can predispose patients to infections, which is problematic. So they looked at this in the mice model. So they had two groups of mice. One group of mice got the typical mouse diet, little pellets, totally unedible. And then the other mouse diet, they had Fritos, they had Oreos. I mean, the pictures from this are actually pretty funny. So they ate like anything that we would basically eat, especially as a resident on call. So they had these two groups of mice, they infected with the exact same amount of bacteria. It's an oral pathogen. And they found that the ones who had the diet-induced obesity, even though given the exact same amount of bacteria, had greater bacteria count at the end of the day because they couldn't clear it as well, and higher alveolar bone loss. So interestingly enough, we know bone loss is a problem for orthopedic surgeons, was seen also in a mice model. The other thing that we obviously know of is wound healing becomes a problem, right? We've all closed it before. A patient who's obese, when you try to close the tissue doesn't come together well. It's not good adipose tissue. It just kind of layers up and it doesn't feel good at the end of it. So you've increased dead space afterwards, and adipose tissue healing is just not as good as to muscle, of course. So this is really where I think the numbers came from. This is back in 1998, where they kind of delineated the magic number of 40, right? Because patients asked the time, why 40? Why not 45? Why not 35? Why not 50? So this is a study where it showed 22% wound complication if over 40 and only a 2% wound complication when under 40. So this delineation was essentially born at this point in time, and people started using 40 as the magic number. We asked the question of whether or not the actual depth of the fat made a difference or the adipose tissue made a difference, or was the magic number of 40 or 35 or whatever it would be. So we actually took knee x-rays and we looked at anterior and medial fat. Now the only disclaimer here and the biggest limitation of the study is if their adipose tissue was off the cassette, we had to exclude them because we couldn't measure it. So we missed out on a bunch of patients that way, honestly. So we looked at anterior and medial soft tissue thickness based on x-rays, and we found that it was an independent risk factor for PJI after total knee arthroplasty, which is where they do sometimes say, patient is wider on top and skinnier legs. Maybe that's actually an okay thing if you're doing especially a knee replacement. Excess adipose tissue around the surgical site can predispose patients to periprosthetic joint infection despite their BMI. So you could have a low BMI patient with a large leg, and that's problematic. It does not heal well. We've seen this before. Versus on the other side, you can have a patient who has a higher BMI, but has thin legs and may be okay. So that's one of those things we don't actually have a full handle on it. So what do we do? So in our institution, we have a cutoff of 40. You guys have a cutoff here as well too? Also 40? All right, so 40 is kind of the average that most people do. In NHS in the UK, it's 35. If you're not over 35, you can't undergo surgery. And they have just so many patients who need joint replacements and so little time to do them in, is that it's just a cutoff to be able to get more patients in at the certain cutoff to optimize patients and reduce readmissions. And we know that Dr. Su is a readmission king, so he will let you know if you're in trouble. So don't get in trouble with him. Make sure that you keep it so that your optimization levels are good. So we do preoperative patient weight loss, and we do that either through a nutritionist and we do a nutrition consult. We're actually doing a prospective randomized trial now, and this was strange during COVID, where we're finding patients with a BMI of 41 to 47 and having them lose weight prior to surgery, and we were mailing them scales because they couldn't come in to get their weights. So they would mail scales, take a picture, and upload it to us and send it to us. So there's creative ways that we can do these studies, but we're actually seeing if it makes a difference with the remote dietitian. So COVID has been helpful because we're able to institute a remote dietitian, have them talk to our patients and make a difference in that way. The flip side though is obesity is problematic, but we also have malnutrition. So you have patients who are obese, they lose a lot of weight, and interestingly enough, they can become malnourished. So I always tell patients, don't just stop eating. That's not the way to go. You have to be healthy in how you eat because you want to lose your weight carefully. So these are different markers of malnutrition that are available. And people use all different numbers here. Albumin seems the one I think the joint surgeons used to go to the most. Plastic surgeons, a lot of them like prealbumin, total protein, total lymphocyte count, iron, serum transferrin, and then vitamin D12 is something that we've taken interest in Boston. We don't get as much sun as you guys, so we have to take an interest in something where we can try to get a little bit more of it. So malnutrition, the problem is that there's increased risk of complications, hematoma formation, infection, renal and cardiac complications. So it's not an easy treatment, right? You have people who are malnourished and you say, okay, you can have a lot of problems with it too. BMI 30, greater than 30 was present in over 40% of patients. So just because their BMI is a quote normal BMI or even a higher BMI does not mean that they are completely nourished. They can still be malnourished. So it's important to check. Do you guys check nutrition levels on patients? All right, and that's an important thing too. Again, these are all things that we added that we never used to do. I say that we're kind of medical doctors actually when it comes to optimization of patients. I know you guys gave a talk where it talks about smoking and reduction of smoking, and it's actually helping PCPs and patients get better. I think in the future, we've already talked about the macro scale. On a micro scale, there's a bunch of different nutrition levels that we haven't hit yet. And this might be for future research for you guys who are interested in it. Vitamin B12, folic acid, vitamin C, vitamin A, D, E, zinc, chromium, selenium. All these little ones that you look at your multivitamin pack and there's like 85 things listed in the back. You're like, I don't know what I'm sticking in my body, but I'm going to pop this pill and hopefully live forever. So these might actually be really useful for you long term. It's hard to be able to tell. So these might be the next generation of what we do for optimization of our patients. So what do I do for my patients? If they're malnourished, 14 days prior to surgery, I'll give them a nutritional supplement. The key factor in my mind, though, when it comes to nutritional supplementation, this is going to show up over there, but the focus of here is the glucurna shake and the boost glucose control. And the reason that I like to do those is because those have lower sugar. So even in my non-diabetic patients, I want to make sure that they have lower sugar levels and not high sugar levels, because those insurers, those regular ones are really, really high in sugar. And the last thing I'm going to do is make someone diabetic because you've given so many of these. So I try to stick to that. Vitamins and minerals are obviously good. Protein bars, that's how I got through residency. We're actually have a lot more sugar and a lot more fat to them. One of the areas that we took a big interest in, again, is vitamin D. So vitamin D, one of my colleagues, Wolfgang Fitz, has been looking at vitamin D patients and optimizing them for years prior to getting there. And so what we did is we paired with our endocrinologist, and we have a pretty intense regimen when it comes to vitamin D supplementation. So if their levels are above 30, wonderful, go home, enjoy, don't stop what you're doing, it's apparently working. If it's between 10 and 30, this is our regimen that we use. We do 50,000 for twice for the first week, and then we do it once for 3 weeks, and then we do 2,000 daily, which is higher than what most people recommend. They normally say 800 is enough, but we do this for a supplementation if they're in this range. If they're under 10, we actually cancel their case. We say you need to see an endocrinologist and you need to do 50,000 IU per week for 8 weeks beforehand. So it's a pretty intense regimen. So we wanted to say, okay, this is interesting. Does this make a difference? So we're now doing a prospective randomized trial. We need 1,000 patients. It's a very slow process, as you all know from doing prospective randomized trials. We want to test to see if the preoperative correction of vitamin D deficiency, low versus high vitamin D in primary total joint patients can reduce 3 months complications. If powered for PJI, it would take forever. We need a lot more patients. So we put in reoperation, readmission, and PJI, which are all relevant outcomes. The most interesting thing here is I really wanted to do a study where it was no supplementation, because that's what we do in practice for a lot of us. Harvard said no. So our IRB said, no, that's not ethically correct to not supplement a patient who you know has a low vitamin D. But we're like, but we don't know what their vitamin D is now because we're not checking. Anyway, so we do low versus high randomization. So the low dose basically gets 800 the entire time and doesn't get a high dose hit, versus the other ones get the high dose hit at 50,000. And we're going to see if that makes a difference. Well, we've preliminary results so far with 200 patients show that we actually are able to supplement patients to more sufficient levels, even with the lower dose. We haven't been able to follow 3 months for everyone yet, but we haven't seen any complication differences yet. So this could be interesting. You could get away with the low dose and be enough, actually, which would be interesting to say. Just take an over-the-counter one, low dose. Interestingly enough, the 50,000 one, it's available on Amazon and it's available for a good price. So patients actually buy it and say, this actually works for me. It'll be interesting to see what it shows. So now I'm going to tell you guys go get a bunch of sun, but don't go outside and eat. So go get sun, don't eat side. This is a McDonald's ad, free diabetes, the purchase of a large Coke. So this is what happens. You can supersize it. The hard part about hyperglycemia, it happens regardless of what happens. If a patient comes in normal glycemic, surgical stress antagonizes insulin, and that's problematic. So just the stress of surgery is going to increase your glucose levels, and it predisposes these patients again hypoglycemia. And the biggest problem with hypoglycemia is not just the sugars themselves. We all get hyperglycemia when we eat a meal, but it impairs the ability of leukocytes to stop infection. And so we obviously need our leukocytes to kick in after surgery. We get some bacteremia from the skin surface itself. You need your immune system to kick in and say, clean this out. So it impairs our leukocytes from working. And hyperglycemia predisposes both diabetic and non-diabetic patients to infection. So patients are like, well, I'm not diabetic, I'll be fine. Sugars don't matter to me. And because we talk about the sugars, right? And I go, no, 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 you don't understand. As a patient, this affects you diabetic and non-diabetic. So a group from the American Association of Hip and Knee Surgeons came together and said, well, what's the cutoff? Hemoglobin A1C is a cutoff of 3 months from the last time it happens. And they came up with 7.7 as a magic number. So we started off in our group and we started off with 7 as our cutoff, and we found it to be a little strict. So now we go to 8, which is hard and goes to show that it's kind of a fluctuating number. 7.7 is what they came up with. What do you guys use here? 8, yeah, 8 something that people can achieve. It takes time, and we want a glucose of under 200 ideally. If we're a glucose over 400, our anesthesiologist will not induce and take him back to surgery. So this is a good marker if it's 3 months in advance for hemoglobin A1C. What if you want something else? So this is another one here, fructosamine. Fructosamine is glycosylated albumin. So what happens is it gives you a marker for 2 to 3 weeks as opposed to 3 months. So hemoglobin A1C is a lot longer. This one is only 2 to 3 weeks, so it's a shorter one. This is with Jay Parvizi's group at Roth Institute, and they found that 292 is the magic number cutoff. And you can see down here at Noam, they looked at this whole setup here of superficial, deep infection, medical reasons for readmission, reoperation, so any of these complications, and found that overall, if a fructosamine was over 292, which is the large red bar, then that was the most problematic one that you could see with patients. So you can see this here as the cutoffs in all different areas. They look at hemoglobin A1C and they looked at fructosamine and found that the fructosamine greater than 292 was actually more discerning than a hemoglobin A1C. So this is something that's available. We don't regularly check it in our practice, but it's something that's available that you can look at too, which is nice. One thing that we wanted to know is, okay, we've been getting all these labs on patients post-op day 1 after surgery. Does the sugar level matter? And at what level of glucose does it make a difference where your risk of infection increases? And we looked at post-op day 1 levels because by then, obviously the surgical stress is technically at least over, but we're grabbing all these labs and these patients are normally fasting next morning, first thing. So let's grab their labs and see what it looks like. And we were surprised to find that the level was as low as it was. So at a level of 137, which is not very high, you know, you eat half a breakfast sandwich and boom, you're probably up there already. At inflection point is where the increased risk of infection happens in our patients. So, and this is post-op day 1 in the morning. So checking your patients, go look at those labs. We looked at this and we said, all right, this is a problem because our patients are spiking and it's not by a lot, and this can increase the risk of infection. So what do we look at next? We said, okay, we wanted to see what the timing was when it regards to the highest glucose levels. So when we were at Brigham, again, with my colleague, Wolfgang Fitz, we said, all right, we have these patients here. Let's test their glucose levels throughout it. We don't have continuous glucose monitors on a patient, although there was a recent grant done by Victor Hernandez in Miami that they're gonna do continuous glucose monitoring. We check patients' glucose right before surgery, right after surgery, 5 p.m., 9 p.m., and the first thing in the next morning. We had all these glucose levels and you can see them put out here. And we wanna say, okay, what point in time is the glucose level the highest? And probably we looked at this from 2017 to 2018. We had over 1,500 patients. And this is a retrospective study. And we defined hyperglycemia as a blood glucose greater than 140. And what did we find? We found that the worst was post-op day 0, 9 p.m., which probably doesn't surprise you. Probably people have eaten by that point in time, have had things in their body and gotten them things. So that 9 was when we were like, okay, we need to be worried about this level because even if they're non-diabetic, they can actually have a glucose spike and that can be problematic. So we said, all right, what's an easy solution that we can do to try to keep this lower or just keep it more level? So we say, all right, you've come into the hospital, we're giving you hospital food, but we're not going to give you just normal hospital food. We're going to give you a consistent carbohydrate diet. It gives you two things. One, it regulates your glucose, and two, makes patients not want to stay in the hospital. The food doesn't taste as good. You go home. It's kind of a win in both ways. So, this is good for your health, and it's actually part of my risk discussion now. When I templated it, maybe it was Epic, I templated it, I put it in there, and I said, we had a discussion that we're going to check your glucose, and we're going to control your glucose levels during in the post-op period. So interestingly enough, we broke this down by non-diabetics and diabetic patients. For diabetic patients, they're pretty used to regulating their glucose and they're regulating their diet. So for them, they didn't make a big difference when we use a consistent carbohydrate diet. But our non-diabetic patients were actually more regulated and had lower glucose levels when we put them on this consistent carbohydrate diet post-operatively. So we place all patients on it post-operatively, and we've expanded this from joints. We do this in actually everyone in our Brigham and Women's Faulkner Hospital. So our other hospital, we have a little more control of it. Joints patients, foot and ankle patients, hand patients, anyone who gets admitted gets a consistent carbohydrate diet. Now, obviously this changes in our outpatient setting, right? We can't regulate it, but we try to tell our patients, try to keep a glucose level by keeping a good diet after surgery with less carbohydrates, more complex carbohydrates. So we're taking away carbs from people, which we love. Now we're going to take away smoking from people, which they also love. So we're going to take away everything fun, essentially, when it comes to preoperative patient optimization. So smoking has some short-term complications on hip and knee arthroplasty, and it also increases the risk of reoperation infection. This is a retrospective study that we had done when I was done at Rothman. So nicotine causes microvascular constriction. Go back to your medical school days and think about what nicotine does. It increases carboxyhemoglobin, it decreases oxygenation of tissue. And so because of that, it decreases wound healing. If you have decreased wound healing, can't get blood to the extremities, then that's gonna be a problem with your long-term outcome. So serum cotinine levels is one thing that we check, and we check our nicotine levels. Do you guys also check as well too? All right, so we send these out and it takes forever. We send them to Mayo and it comes back after a little bit of time. So this is my regimen personally. Patient comes in, say that I'm smoking, I go, quit smoking. Once you quit smoking, call me. 2 weeks later, I'll test you. I won't give them a surgical date, because if I give them a surgical date, then they're just gonna be like, oh, I quit smoking. I'm like, oh, when did you quit smoking? And then you check, you're like, they quit smoking this morning. It didn't actually mean quit smoking. I check them after 2 weeks of quit, and if it's negative, then I put them on the surgical schedule. I do not check again. Some people have like a breathalyzer test that you can actually use. You can actually check for nicotine levels in that way. So that's something that's an option that you can have. Personally, I just use the serum one, but it takes a long time to go out and do it. Serum blood saliva, you can check it in. Half-life is 20 hours. It predicts smoking within the last week, and you want to get under levels of 10. So when do I tell patients to stop? I take everything fun away from them 4 to 6 weeks prior to surgery. Immune and metabolic function do normalize, and you have decreased complications if you do stop. So patients go, does it work, doc? And I go, yes, you should stop doing it. But 4 weeks later, you can restart again. And actually, I go, look, you're going to save, $7 a pack. You're going to save a lot of money. The patient just told me that this, 2 weeks ago. I was like, oh, it's good to know. I'm going to use that in my talk. So $7 for each pack, so if that's once a day, that's a lot of money and adds up really quickly. So it becomes really expensive, and it's going to help the rest of your health. So it's a good thing overall. So the other advice that I talk about is alcohol. So alcohol abuse, you have to ask every patient. So I was a resident, and I asked a patient, I go, well, how much do you drink a night? And he goes, 2. And I'm like, oh, okay, 2 glasses of wine a night. It's not great, but it's not the worst in the world. Turns out he drank 2 bottles of wine a night. Needless to say, DTs kicked in, patient was in the hospital forever. And I learned my lesson that you always ask how many, quantify it, and make them be honest with you. They still might lie, but you should ask for your patient. Patients tend to be a little bit more honest to their physicians in theory, but that's the thought process, because patients almost always underestimate this. And you, again, want to quantify how much they drink. So how much does it mean? This is a scale of what alcohol abuse is, which is 40 units per week. And I'm not surveying anyone about how much alcohol they drink per week, because we have to survive. Let's say a small glass of wine is 1 standard drink, half a pint of beer, and it's a single measure of spirits, small amounts. So you look at that, you get a full pint, that's already 2 or 3 per unit. And that's only one of them. You have 2 or 3 or 4 glasses. We're not going to talk about the residence event last night. And all of a sudden your numbers go up. You have a bottle that's 9 units, and it's only 40 to get to alcohol abuse per week. So it's actually not that much, which is interesting. And again, the problem with our patients, it's not just the alcoholic content, but really what does it do to you? So studies have shown retrospectively that there's increased length of stay, hospital, surgical, and medical complications. It affects everything in the system. So again, I take everything fun away in 4 to 6 weeks. Alcohol cessation, minimum of 4 weeks. Interestingly enough, immune competence gets better afterwards. Wound healing capacity improves after 3 to 4 weeks, and reduced postoperative morbidity after 4 weeks. So it does make a difference, in all honesty, to get the alcohol out of their system. And again, this saves them money, and they can go back to it afterwards. I wait till after the wound heals to do so. So to finish, so to talk about preoperative patient anemia. So optimization of this, the WHO tells the guidelines of women under 12 and men under 13 as anemic. So what do I do in these patients? If they're under 10 and 30, I have them go see someone, either PCP or HEMONC. PCPs are overloaded. They're working their butts off. They're doing a lot of other stuff. So HEMONC, if it's problematic, if it's not something they've lived with their entire life, I have someone see them because maybe the first time they're actually really looking into it. Most of the patients in Boston come in already having know this and seen someone for it. What are the reasons that you can have it? So there's nutritional deficiency. And again, I'm talking about modifiable risk factors. That's my focus here. So iron, folate, B12 are things that we can address. We can do things about it. You have chronic renal insufficiency, chronic inflammatory diseases. It's a lot harder to do something about it. They're probably been optimized by that point in time. I just send a letter to their doctor and say, hi, how are they? They're nephrologist or they're a rheumatologist. And they're like, there's nothing I can do about it. This is what it is. And I say, okay, you've gotten to the point that they're happy. That's good. But if they can be optimized, for example, iron, here's an example what they can do. Now, here's a cartoon that says, I know iron tablets are expensive, but BBs don't work as well. Don't give your patients BBs. It probably won't go well in your health grades report. But besides that, oral iron is the way to go, right? So you give them 325 3 times a day. The downside about it, patients get constipated. So I tell patients, take your Senna, take your Colace, drink your prune juice, whatever you enjoy, keep yourself regular because this will constipate you. So I do it 3 to 5 weeks prior to surgery. This is another option that we don't regularly do. It's intravenous iron. So you can actually, it acts faster. Some people actually come into infusion centers and get intravenous iron. It acts faster. It can be for IV hip fractures, for example, because you can deliver intravenously. And if they can't tolerate oral iron, this is a way to go. It's much more expensive. That's another downside. Everyone knows what Epigen is now, thanks to Lance Armstrong. So it acts like human erythropoietin. It stimulates bone marrow and increases red blood cell production. If you're performance enhancing, that's one thing. Our patients are not performance enhancing. It's to hopefully get their levels up. This is not something that I commonly use in practice, and I don't think that most people do now because of the black box warnings. But in the past, it used to be indicated for Jehovah's Witnesses. They could actually get it. In some institutions, you're getting bilateral hips and knees. You could actually get it because you knew you were going to have a lot of blood loss. So you could actually do that as well. And if they have low body weight, patients could get this and tank them up ahead of time. This is from the Yellow Journal. This is the recommended dosing. Again, I don't use it. Do you guys use this at all now? Yeah, so this is something I touched as a resident and never touched it ever since. And the reason really is that it's expensive, which is only a tip of the iceberg. It's difficult to get approved prior to surgery. And more importantly, as a black box warning, there's black box warnings that you can pay attention to because it increases nausea, vomiting. It's normally not a black box warning. But when it says increased mortality, that's a big deal. So this can increase death. Serious cardiovascular events, thromboembolic events, stroke, and increased risk of tumor progression or recurrence. So this is something that's problematic for our patients, especially in our older patient populations who may have already come in with tumors and things like that. So you want to be careful with it. Not commonly used in practice, but an option. Finally, this is something that's near and dear to Dr. Springer's heart, I know, because he has been on way too many conference calls with a lot of people who talk a lot about rheumatological diseases and conditions. So this actually started back in 2017, where we said, all right, we have a bunch of drugs and we don't know whether to start them or to continue them throughout the surgical period or stop them prior to surgery. So in 2017, the brainchild of American College of Rheumatology and the American Association of Hip and Knee Surgeons convened a panel of individuals who took care of all these different patients and say, what's the balance? And let's come up with a guideline to help our patients. This is the populations that were included in it. And the interesting thing is we're updating this right now as we speak. We'll have a publication shortly in the 2021 updated guidelines. So these are a population of patients, adults, and really it broke it down to a bunch of different conditions. So psoriatic arthritis, rheumatoid arthritis, spondyloarthritis, including ankylosing spondylitis, and JIA and SLE. And they broke down the SLE into non-severe and severe. And severe is just any sort of organ systems involved, and it's considered severe. So really defined population, because patients are like, I have SLE, but I'm fine, I'm not doing a lot. And the other ones are really severe, and it's a totally different ballgame. So what we did is a multi-step literature search. We had wonderful people who did this in the background for us, and we used PICO questions, so patient intervention, control, and outcome. Put those all in there. Methodology is a wonderful thing for Susan. She knows this well. Dr. Odom knows this, the great methodology, and knows this whole process incredibly well. Low and moderate quality evidence, that's the downside about it. A lot of this is retrospective. No one's really done this in a prospective manner. And what I found interesting, because this is my first time participating in this, is there's two things. One, you have a voting panel. And what are they voting on? So you're trying to vote on balancing whether a patient gets a flare, and you want to balance if they're going to get infection. So from an orthopedic perspective, I'm really scared about the periprosthetic joint infection. The flare, we can manage it. But that's what was really cool. They brought in a patient panel and they said, some patients are like, oh, no, you don't understand. I'd rather take an infection and have you cut my leg off than deal with another flare again. So it's interesting to see perspectives of not just us because, I'm infection centric, but the idea is that you want to balance between the flare and the infection. So what do we come up with? And interestingly, some of these are changing in the next guidelines, and I don't want to give it away yet until it's been published because I don't want to get in trouble. So things that change our practice was continuing the current dose of a bunch of different medications. Methotrexate, which are not just used in these type of patients, they're used across the board for a lot of different patients. Hydrochloroquine, my Crohn's patients, sulfasalazine, my Fortic, azathioprine, cyclosporin, Prograf. My transplant patients are on these, and I'm continuing them throughout the period. So that's a game-changing practice because now their flares are reduced or their rejections are reduced, but I still can continue them without a lot of worry about them getting infected. Can they get infected still? Of course. But the idea is that we can actually continue these based on literature and guidance. Withhold all current biologics, so anything that really ends in a MAB or an AB or things like that prior to surgery and based on their dosing cycle. Some are 6 months. I will literally book it for 6 months and 1 day and take them to surgery that day. Some are 2 weeks, so they have a little bit more leeway. So it really depends on the dosing cycle of the drug that they're on. Tocilizumab is one that's a little bit different. For 7 days prior to surgery, that's when you hold it, and then you can undergo surgery. And then restart biological therapy once the wound shows evidence of healing. On average, it's 2 weeks. I see my patients at 2 weeks and 6 weeks after surgery, see if the wound's healed and if they have enough motion, especially for a knee. But in some patients, like one of my patients, she was on one of the biologics. At 2 weeks, I saw her, wound hadn't fully healed. I saw her the next week afterwards, wound hadn't fully healed. At 4 weeks, she finally healed, and then I started her back on her medication. And she's back on my schedule for her other knee now. So we'll see how that goes. And then this is another game-changing one that took a lot of time with my anesthesiologist to understand. To continue the current daily dose of glucocorticoid patients if they were getting under 15 milligrams daily. In those patients, I said, all right, keep it going. And it used to be as a resident, I was giving 100, 150 doses for anyone on any sort of steroids. 5 milligrams, super therapeutic dose, 10 milligrams, super therapeutic dose. Well, what's the problem with getting glucocorticoids at such a high dose? We talked about hyperglycemia. All of a sudden, now you're balancing between the two. Yes, they're getting the stress dose, but now their glucose levels are off the roof. So you want to be able to balance that and give them that, again, flare versus infection. You don't want to make them worse because of something else. So in conclusion, you want to optimize your patients prior to surgery with modifiable risk factors. Everything I talked about are things that we can do something about. It's not just something that's an esoteric pie in the sky or, a patient gender. You're not going to change that for the surgery itself. Work with other specialists to improve patient care. Again, we're orthopedic surgeons. We're not great at optimization. We can get the ball started, but we have people who are really good at this and they can help us with the process. And don't just stop at the preoperative optimization, right? Do intraoperative and postoperative optimization as well. Thank you very much. Any questions? Oh,
We're going to use a mic so people online can hear some questions to start with.
Antonia, thank you. That's a great talk and overview with your research. We have a question. I think we always battle on some details about the codenine nicotine testing and the timing. So for you, you said, patient contacts you when they've officially quit. You schedule them.
I test them first.
You test them.
I wait 2 weeks and test them and
Right.
then schedule them.
So then you schedule them. So between your test and your OR date, what happens?
They can pick up smoking. And
So
that's,
is there have you tried it any other way? Because when we put it close to the surgery date, then we end up canceling a lot of surgeries, right? Last minute.
right, that's
So
the hard
that seems to be a struggle for us. And it seems the most important time frame is that immediate perioperative time frame. So have you tried anything else in those?
So we
scenarios?
haven't yet, and the only reason we haven't yet is because the testing takes so long to send out and get back that it becomes problematic. So there are these breathalyzer tests I think people use, and so those would be the ones to do probably like a week before, and then you can fit someone else into a schedule in the time frame. We have not had it. We kind of take them at their word and say that they do it. So that's the hard one. We have not. We use the honor system a lot in Boston. Whether or not that's actually good, that's a whole different ballgame. But we do not do anything else. That would be the breathalyzer test is what I would say. Maybe like 2 weeks prior to surgery, test again, and then cancel them. You can put someone else in the schedule in a 2 week time frame. But if it's too close and you're canceling, then you're just leaving the slot open. That's the hardest one.
And Antonia, thank you for a fantastic presentation and all your work. This is critical to really the care of our patients and making sure we get good outcomes and do the best we can for folks. You mentioned the situation in the British system, and I have to say that's weighed heavily on me. And thinking about this for years now, where do you think that line is on a socio-political level between optimizing care of our patients and rationing care to save money?
COVID brought that to light. That's the scariest part, right? Rationing care for our patients. So this is a debate that I get into with people, fortunately, unfortunately, people's like, well, by limiting people who have body mass index of 40, for example, right? Because that's the easiest metric right there to go across. There's a lot of socioeconomic downsides that come with it. So there's a lot of our colleagues that we know who publish and say, if you're doing so, you're restricting care to this population of patients. And this area, it's not just weight at that point in time. So a question I get sometimes is, okay, patients optimize on everything else and their body mass index is a little bit high. Is that a reason to not do surgery? And there's studies that support doing surgery in patients with larger body mass index and gives them better quality of life. So the answer is, I think we are restricting it. The hard part is when it comes to rationing care, there are only so many patients, so many joints, for example, in the NHS system or the Canadian system, right? And if you can optimize the patients to give them the best possible outcome, then it makes sense across the board. In COVID that happened, people had to decide who's going to get a ventilator, who doesn't, because there's only so many ventilators possible. Who's likely to survive, who's not likely to survive. That's the most dangerous and scary place to be in all honesty. So I think our roles as physician is to provide the best care possible. So if that means not restricting, but giving and encouraging patients to improve their health, I think it's part of the narrative. When I talk to patients about body mass, like when their body mass index is higher, I draw a graph and I go, for whatever reason at 40, it just exponentially gets worse. And I want you to have the best possible outcome. And this is where shared decision-making actually becomes a really good part of the discussion. It's like, I'm not trying to not give you a joint. And I'm like, I'm sure you can find someone to give you the joint. But at the same time, I want you to be healthy. So no matter where you go to, I would highly encourage you to lose the weight so you have a better outcome, so it improves it. So it is rationing care to a point, but we're not doing it to ration care in our country, thankfully. We're doing it to hopefully optimize the patients prior to surgery. But you're right, when it comes to rationing care, 35s are cut off now. It could be 30 next year. It could be 25, and then all of a sudden you really are rationing care and it's affecting a lot of different patients. So I look at that and I kind of say, we're doing this together to try to make you healthier. And hopefully that patients understand that. Tough.
Thanks, Antonia. And actually, along those same lines, this is interesting. We got a call last week through one of our national organizations that there's a large insurance provider down in Florida that is now restricting, denying access to joint replacements for anybody 35 and over. So it's an insurance provider in Florida that's restricting access based on their, covered lives BMIs greater than 35, and so a lot of the physicians up there were up in arms. They started calling some of the national organizations from an advocacy perspective. So it's definitely happening. The insurance providers may be the ones that may end up doing more of the restrictions even than us. Thanks for a great talk. Question for you, because we're going through a little bit of the same transition here, I think you did, with regards to MRSA screening. So we were historically a universal screening and selective decolonization. That's what we've always did. That's what I was a huge advocate of forever. So test everybody and then just treat those that are positive, and you give them mupirocin, just like you talked about, and identified the positive carriers and adjusted their appropriate antibiotics. But when COVID hit and we went to virtual pre-op visits, it became logistically very difficult. And as you mentioned, who's responsible for the test, who's checking it, are the patients actually compliant with their mupirocin? So we've tried to, across the Atrium system, implement just universal decolonization. I was always of the belief that identifying the positive carriers was the most important, so that you would then know who to give the appropriate antibiotics for. And maybe that was more important than identifying the patients. But now that we're universally decolonizing everybody, how do you guys decide who to give vancomycin to? Because it's 6% of our patients are MRSA positive, so you don't want to unnecessarily give vanco to 94% of the patient population. So what did you guys decide to do parameter wise? Who are you giving vanco and Ancef to?
So we're still screening. That's the
still
thing.
screening
We are
everybody.
still screening patients. So it's one of those interesting things. We are still doing universal screening, universal screening and not universal decolonization, actually. The decolonization we're doing at university is just the chlorhexidine wash.
Okay.
And we don't give mupirocin to everyone. But we do the universal povidone iodine in everyone's nose. But what's interesting is when I got there, so John Wright was there before me, and for whatever reason, our MRSA spiked. And when our MRSA spiked within our hospital system, anyone who got any implant got vancomycin. And this just went with trauma, that went with cardiac, that went across the board, entire hospital wide, that everyone got vanco and then ancest simultaneously for everyone. We've taken years now, Rich Iorio and I have been detangling that and trying to remove that because it just wasn't, there have been studies that show that dual dose antibiotics are beneficial. We thought it was just too much. So now we've pulled it back, and now not everyone who's an implant has to get vancomycin. If you're a healthcare worker, if you had a previous history of MRSA, then you'll get it. And some people will give it to like diabetics, like more immunocompromised patients, but that's the whole debate between antibiotic cement versus non-antibiotic cement. So really our two main criteria is healthcare worker or nursing home person, which is not very common for us, but nursing home individual, a healthcare worker, and then a previous history of MRSA. And then that kind of covers a certain percentage of people. So that's the thought process. But we still do actually screen now, and it is logistically very difficult. So I've actually done a lot of MRSA swabs in my own clinic. So if they're within, so we start down with our preoperative testing. It used to be 4 weeks beforehand, which is really hard. You're not scheduling someone, putting them on the schedule. But at 6 weeks, at some point in time, we're actually getting patients on a schedule within 6 weeks. So if they're within 6 weeks of surgery, they actually let us bump it out to that point. I will test for MRSA and MSSA in the clinic. And if not, they can actually get it locally, and then they can send the results in. So instead of having to drive in, we get people from all over the place, as you guys here do too. And so what we'll do is we'll have their PCP or someone locally test it and then send us the results. So, and same thing with COVID. At first, COVID had to be one of our facilities. And we have a bunch of different facilities around the area, so that was helpful. But now they can get from their local ones and send it in to us.
So we have a question from Mike Bates, who's watching online. Mike, you want to go ahead?
Yeah, good morning. You able to hear me okay?
We are.
Number one, thank you for this talk. I think it was well presented and just really critical information. I wanted to ask you a question about your the smoking cessation policy. Recently, one of our residents gave a great talk on smoking in the perioperative period. I believe that was Dr. Olivia Rice, and made a distinction between nicotine replacement therapy and actually smoking. Of course, with the nicotine replacement, you don't have the concerns with the carboxyhemoglobin and the associated oxygen carrying capacity. So my question to you is that a distinction that is being made at your facility, and if not, is that something that's being considered in as a way to help people stop smoking and still obtain surgery?
Thanks for the question. So that's one of the tough things we've grappled with. I've talked to some of the Mayo guys about this, and they say nicotine replacement patches are fine. They can do those. So and that's where the nicotine and cotinine come together. So I don't just test nicotine, I also test cotinine too. And the cotinine levels will be high. It will be, the nicotine levels will both stay if you have the nicotine patch and if you're smoking, but the cotinine levels will go down if you have the patch as well. So this is what I tell patients. I go, it's actually passing through your lungs that actually is problematic. And this has been nice because it's been able to predict that, like, well, what if I, vape? What if I smoke marijuana? What if I do these other things? And I go, anything that goes to the lungs, I don't like it. So I'll talk to my patients about that. If it goes to your lungs, don't do it. Gummies doesn't go through your lungs. You know what I mean? Putting CBD oil, not going through your lungs. Those are okay. Don't love them, but they're okay. But the smoking aspect of things, for whatever reason. So in those cases, I tell them to stop the smoking of cigarettes, cigars, the whole 9 yards. But a nicotine replacement patch is actually shown to be okay in what some of the studies have shown. I don't know if that's what was presented as well too, but I will allow for nicotine patches as well.
Dr. Chen, this is Joe Shu. Question about Medicare and potentially lobbying Medicare. So a lot of this preoperative optimization is really put on us. Yet on the back end, Medicare penalizes the hospitals for readmissions and for really quality related things. So at what point should we, or will it make the situation worse for us, lobby Medicare to actually put some of this stuff in their pre-certification, where people are actually optimized before they're pre-certified for surgery, or is that opening Pandora's box?
I'm gonna go with the latter.
Easy question, easy
I know.
question.
So I definitely think it's opening Pandora's box, right? So it's interesting. One thing is Medicare, I think, is actually recognizing it, right? They've now given us a code that we can use for preoperative optimization time. And their physician assistants can bill for it if they do a preoperative optimization visit prior to surgery. Now, the downside is if you don't do that visit, you can't bill for it. So, one of my colleagues does it. His PA has a clinic where they literally just call patients up and do virtual visit pre-optimizations, and that seems to work. For my PA, she literally has a list of like 10 things that she has to chase down and like constantly follows up, because people don't respond because it's just so hard in this era to keep up with everything. So why I think it's opening up Pandora's box is because if we make restrictions, it's going to be like the NHS. It's going to be like saying, okay, if you don't reach this, then you can't have surgery, you can't do it. Then all of a sudden they're prescribing us what we can or cannot do as physicians. And that becomes a little problematic. But I think in terms of the onerous, I think the onerous would be ideal from a hospital perspective. They give you the resources to optimize because they recognize that reducing readmissions is beneficial to them. Reduction or operations are beneficial to them. So all of a sudden they say, okay, now we're going to give you a physician assistant or a nurse practitioner or someone, an advanced practice provider to help you optimize. That person's going to chase down all those things for you to free up your APP to do other stuff, surgery, clinic, things like that, which they should be doing, not chasing down these optimizations. That, in my mind, would be the way where the hospital is putting their money where their mouth is and saying, okay, we're going to be dinged for this, so let's help you do the process. And if everyone had an optimization APP and the regular APP, that'd be amazing, right? But that's obviously not going to happen. But to have that person, the hard part is who does what and who's going to cover what. This is the tough part, but I think that would be a neat way to go forward and put the onerous then on the hospital.
So the answer you just gave leads right into the question that I was sort of getting ready to ask. You've worked in 2 major institutions. You show lots of data points we can look at to improve things. But I think all of us know the real barrier is what is the system and how does the system facilitate this? The system should facilitate it because the system, as we just mentioned, and you guys both alluded to, gets penalized for it. It's not necessarily the doctor themselves. So what are the pearls that you've seen? What are the things that work well in your system? Is it a pathway in an EHR? Is it a navigator? Is it an APP? What are the things that could reduce these barriers and improve the smoothness of this process? Because there's probably, I mean, I can tell you from our own institution, real penalties for these bounce backs, readmissions. It's real.
It's a big deal. Now we're not in a bundled system, so that's the difference. So my readmission reoperations are not tied to what I am in our system, just because we're part of an ACO, and that becomes a different setup. That said, it's a really good point. So where I came from at Rothman, they had nurse navigators, and the nurse navigator would be from start to finish, be with them the whole way, and kind of walk them through everything, which is really nice because then you literally could hand it to them and say go. So my APP had to do a little less work in that area. In our area, we actually did hire optimization PA, and she's fantastic, except for the fact that it's a back and forth of even like a MRSA comes back positive. Who treats it? The optimization PA or my PA? And they've had exchanges of emails back and forth. And I'm like, wait a second, it should be seamless. So the system in place is not always seamless, as we all know in all of our practices. So APP does it more in my facility now versus a nurse navigator. And as long as it works for a system, it works. But it depends on these system setup. So there it works very well. And like in Rothman, they do a nurse navigator, walks through the whole process. My APP just handles my practice and my patients. And so we know exactly what it is and who to reach out to. And that seems to work for us.
Any other questions? Anyone else online have any questions? Always got to wait for a second to make sure people find the mute button.
I know. Mute off, not video off, because it's problematic.
All right. Well, thank you very much. That was a fantastic day. We all